labor room prioritization. Labor room prioritization is a very important station in labor and delivery module, and it's always there in exam. So you should be really well versed with it. Sometimes it can be challenging how to talk, what not to talk, because there's too much to talk and there are so many scenarios, like 7, 8 patients if they give you have to talk about each patient and you have to finish the station in 10 minutes. So sometimes it is very challenging that how much to talk, when to stop, which is important, which part I can leave. So please be clear that sometimes you might not finish the station, that's acceptable. As far as you're doing fine, it is acceptable. But that doesn't mean that out of 7 stations, you will cover only 2. That means you have not done it correctly. Out of 7, if you cover 5, 6, it's acceptable. So you have to keep a proper speed, and as well as you have to understand what is important, what is not important. Then only you will be able to finish this session. Don't keep talking about one station in all the finer details. They're not asking you that. They are telling you labor room prioritization. You have a group of people with you. I will tell you, when we take the rounds here, like when I go to hospital in the BARTs, and when we take the round, we have an anesthetist, okay, an anesthetist consultant or their ST5 or whatsoever, so senior one. So we have an anesthetist. We have our obstetric consultant. Then the ST5 or ST3 plus anybody can be there. They are registrar. Then we have one ST1 or ST2, which is the SHO. And then we have the midwife in charge with us. And then in every room, there is a midwife who is taking care of the patient, one-to-one care. Because the hospital delivery means they are high risk, so they need one-to-one care. So always one midwife will be in the room. So this is how the team goes in the morning, so many people. And we in our country, we are used to going only single, maybe sometimes single or 2 people at a time. So that's why this is difficult for us, because we don't do it. But for people here, it is very easy because this is what they do every day. So I will give you the tips of how to handle this prioritization and how to handle this discussion about the patient. And let us first start, and then I will give you the tips. Okay, so Mariam, can you start, my dear? I'll give you 2 minutes. So can you just read it, and then I will show you the chart and I will give you 2 minutes. So this is your team. This is a structured discussion, and this is your team.
I can read loud, no?
You can, no problem.
You are ST5 in labor room and are taking charge at 8 a.m. Consultant is on his way. You have ST1, ST2, ST4 anesthetist, senior midwife, and 3 more midwives to manage labor ward with you. You are expected to prioritize the cases, assign tasks to your team members, and plan safe management.
Okay, great. So this is your board. So you can go through it, and then we will start after 2 minutes.
Yes, and now we start.
You ready?
Yes.
Okay,
But
so
I would like
let
to.
me set, wait. Let me set the timer for 10 minutes. Okay, start.
First, I would like to go room by room and prioritize the patient. My priority might change anytime according to the room later. So first, room number 1, Mrs. Mel Lane. She delivered spontaneously, forced gravida, bleeding about 1.5 liters. I would like to check extra IV line group. I would tell my ST1 to my midwife to put on extra IV line, take blood for cross matching, inform for blood, and I will start the uh, PPH protocol, and I will inform my consultant, and I would like to start. First, I would like to explore the locally, like if, what is the reason, check for a uterus if it is contracted or not. If it is contracted, I would check for tears, anything. And meanwhile, I will start the fluids. I will ask the midwife to start the fluid, and according to the if the bleeding is not controlled, I will go for the next step, syntocinon to be started 40 units in the IV drip, and then further I would like to inform the anesthetist to keep the theatre ready. If it is not, I will go for the next surgical option of uh, 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 tamponade with surgical tamponade. Then I will further proceed with the PPH protocol. Next, I would like to move to room number 2, primary 37 weeks, induced now fully dilated with the pathological Ctg. Um, since the Ctg is pathological, I would like to start the conservative measures first, and I would like to assess the patient, patient vitals, BP, everything. Then I would like to see what is the position, station, already fully dilated. So I will opt for instrumental vaginal delivery depending upon the station. I will go for it. And I will moving to room number 3. Para 1 delivered, waiting suture repair. I will ask the midwife to suture the perineal tear if it is grade 1 or 2. And room number 4, VBAC fully dilated, pushing for 1 hour under epidural. So it's third gravida, so we can wait for 1 more hour since she is under epidural. And I will check the vitals, Ctg. If it is fine, I will move on to next room. Primary 39 weeks, card felt by midwife during vaginal examination. The Ctg is reassuring. I would like to inform the theatre anesthetist to proceed for cesarean section category 2, category 2. And next, I will move room number 6, second gravida, antepartum hemorrhage, 175 ml. No active bleeding right now, B negative. So I would like to ask my ST1 to check her history, anti-D, whether it is given or not, like accordingly. If there is no active bleeding, we'll just keep her for observation. And room number 7, Mrs. Susie, fourth gravida, Ctg showing 9 p.m. early deceleration, like her meconium stent. So I would like to assist her and Ctg early deceleration, so we can wait for her to progress, and just conservative measures can be done.
What can be done?
Conservative measures can be done.
Okay.
So I would like
Anything
actually
you want to add?
Yes, I should go in the first. So I will prioritize first. I will uh, go to room number 1. If it is bleeding more 1.5 liter, I will initiate the PPH protocol and I will be there. Meanwhile, I will, after initiating, I will room number 2. I will since it is pathological Ctg, to start the conservative measures, and since she is fully dilated, we will like to expedite the delivery depending upon her findings.
So whom you will send to room 2 if you are in room 1?
I can just send my senior midwife to assess the patient findings.
Okay.
And so in this, I should go in detail with the first case PPH protocol. I should describe more in detail.
Okay. Anything you want to add? Where you will send your ST3 and ST1?
First, ST1 to get for APH, I can send to get details and collective history, and to anesthetist, I can initiate room 5 for prepare for emergency cesarean to get a concern to explain to uh, initiate the things for category 2 cesarean section. I can send to that, and I can for PPH patient I can tell them to start like to help with the things, and midwife to repair the perineum care.
Pardon?
Senior midwife to repair the perineal care.
Okay, good. Anything else you want to add?
That's all I could think.
Okay, great. So you still have 2 minutes time. So that means definitely some points you didn't cover because you
Yes,
still had 2 minutes time left, right?
yes.
So what do you think? How much you felt the task was easy or difficult for you?
No, actually, I don't know how to proceed with the task only because the first time I'm seeing this. I think I should go in detail with the protocol and I should know whom I should send for each room, what task to be done. And
Yes. So you did some things really great. You went to room first. Your prioritization was almost correct, except you didn't use your ST3 at all. But you went to room 1, which was good, and you wanted your ST1 to go to room 6, which was correct for APH. But here the problem is here too many emergency things are there. You are right that you will go to room 1. But what about other rooms? You have to, it is labor ward prioritization. So you have to tell who will go where. Can you close your mic, my dear,
okay.
so that you can hear to me clearly?
Yes.
Yeah, close your mic. Yeah. Okay, so you did correctly by going to room 1. So whenever there is a bleeding problem, like PPH or APH ongoing, that is your priority and you will go there. Because you are ST5, you are responsible for the labor room and bleeding can lead to death. So definitely bleeding is always the first priority and mother is first priority rather than baby. So pathological CTG is a priority, but bleeding is more priority than pathological CTG. So always, whenever there is a labor ward prioritization, they always give you a bleeding patient. So you will go to that room. If you don't have a bleeding patient, then you will go to either rupture uterus of a VBAC or you will go to bradycardia, abruption, that sort of thing. So bleeding is your first priority. You went correctly to room 1, which was bleeding. So it's a massive PPH. So you have to do the PPH protocol. Here, major obstetric hemorrhage protocol, either you can say, or whatever. MOH call is what you have to tell that I will pull on the emergency buzzer and all will be collected there. So this is your first priority. But then you have to understand who else you will assign which room. And then you have to talk about some of the terms which are important, right? If you go to a woman who has just delivered, she's para 4, means you are suspecting atony. And here you are talking to the consultant. Here, this is not a role play station. Here you are talking to the consultant. So you have to use the medical words. You don't have to use that, I will examine her and if uterus is relaxed. No need. Simply say that as atony is the most common reason and she's para 4. So that means you are processing the information in your brain and tell. So you will tell as she's para 4, she has just now delivered. I am suspecting this is atony PPH, which is most common cause of PPH. And because of her parity also, atony is what I'm expecting. So then you have to tell that I will start her on oxytocin. Don't tell the detail of oxytocin. So I will start her on oxytocin as per the protocol. First oxytocin and then if not control, if no allergy, that argometrine and then carboxyl. So no need of telling the dose and duration and all that thing. Because here they don't want to listen the detail of PPH management. They want to know that you will go in the room and you will do what. So you go in the room and you will do what? Can you hear me now? Okay, great. So you have to only tell, I will collect the blood. I will collect the blood for 4 units cross match. I will collect the blood for 4 units cross match and full blood count and LFT, RFT. You have to tell like that. So your main aim is to go to the room. You are the one who is going to assess the massage the uterus. You didn't tell you will massage the uterus. If it is anatomy, I will massage the uterus, drain the bladder. So catheterize the women. You didn't mention this. This is your first step. So you have to tell that you are going to do this and you will endorse the task for the midwife to do the IV line, to do the blood collection. Even anesthetist can do the blood collection, put the IV line. So they will do that. And the porter will be called, blood bank would be informed. So these are the things. So you have to picturize that you are in front of a woman who has just delivered and bleeding. So you are at the vaginal end, you are massaging the uterus at the same time. You're telling the midwife to give the oxytocin at the same time. Somebody is putting IV line, doing the blood collection. Somebody is informing the blood bank. Somebody is at the head end of the patient to counsel her what is happening and scribbling. And somebody is leading, which is you. So you are the one who is assigning all these rules to everybody. And then you have to tell that if after atony has been managed, if she is not well controlled with all the oxytocins, then I may have to take her to theater. So I will be alerting the anesthetist. I will tell the midwife to alert. You cannot do because you are at the vaginal end. So you'll tell the midwife to alert, midwife coordinator to alert the theater. And it's the job of midwife coordinator to alert everybody. So she will alert the theater, the anesthetist of theater, not the anesthetist with you who is managing with you, the different anesthetists of theater. She will alert them that we might have to take this patient to theater. You have to inform the consultant. You told that you will inform the consultant, which is important. Safety point, because you are not the most experienced. The consultant is most experienced. So communication is colleague with colleague is important. So consultant, anesthetist, and the blood bank. These are the coordination which should go. And as I told you, you have to set the scene and tell that these all I'm going to do for her, and she might have to go to theater for tamponade, what you told, so that all is fine. So empty the bladder massage is what you missed. Oxytocin, you have to tell all the drug after asking for the allergy. If she's not allergic, I will give. Whenever you utter a drug, always tell that after asking the allergy, we will be giving. Starting the fluid, you told we will start her on oxygen. This is what you do. So oxygen, you have to mention oxygen fluid, fast fluid will be run, oxygen will be started. These all things you have to mention. So you did it correctly that you will go to room first, which is completely all right, perfect. But you didn't set the scene properly, and you could have told more about uh, more medically that oxytocin, atony, traumatic. It could be a traumatic PPH. I will look for if there is any tear, any bleeding from the tear, or if episiotomy has been given. So you have to look for that. So this is what you have to mention. This is an emergency. Otherwise, any delivered patient, you can even put a word about baby, that I will make sure the baby is doing well or whatever. So here, anyways, you cannot utter about baby because this is something bleeding. So you will tell that I will manage her PPH, which you did well. Then comes the room 2. Now, because you are busy in this room, you cannot go here. You cannot go to this room or this room. So now your next priority is pathological CTG need assessment, right? Because this already has been assessed. She's a cord presentation and she needs cesarean section. So here, nobody has to do an assessment. So this doesn't need an experienced obstetrician. This can be done even by ST1. So this is not your priority. Your next priority is pathological CTG, which you can assign to your ST3. ST1, ST2, ST4. So you can assign to your ST4. If you have an ST4, you can assign to them. And ST1 and ST2 can do other work. ST2 can go to your cord presentation lady for consenting. ST1 will go to APH lady. If you don't have, if you have only two, like ST1 and ST3, or even sometime one, in that situation, whoever is junior to you, like you are ST5, whoever, like ST2 or 3, whomsoever you have, you will send that person, but not ST1. ST1 cannot assess and cannot make any judgment. So you cannot send your ST1 for any assessment or final outcome or decision making. ST2 onwards, they can decide because ST2 is 1 year already in the field. It's ST1, ST2, then ST3. ST3 onwards is registrar. So ST3 onward, they can do instrumental delivery, they can do anything and everything, cesarean, so everything. So if you have an ST3 or ST2, they can go to this room and they will assess because it is pathological CTG, because it is induction of labor for Iugr. You have to mention, they have given you induction of labor for Iugr. So you have to mention this is a primary women. You have to follow the Sbar tool. That's all I will tell you. So this is primary women, induction of labor for Iugr. So I'm concerned with the baby. So my ST2 will go. My ST2 will go in this room, and what he will do, he will assess the pathological CTG because midwife coordinator is not going to assess this. Now here it needs decision making because it is fully dilated in pathological CTG. So your ST2 will go pathological CTG. So he will assess, he or she will assess the women condition, do the conservative measures, either you can say, or elaborate a little, like give the fluid left lateral position, and we will see if the CTG is improving. And we will assess her vaginally. She's fully dilated. What is the station, descent, how long she's fully dilated, how many hours of active pushing. This is important. You have to use the word passive second stage and active second stage. So active pushing, how many hours of active pushing? What is the station? Is it suitable for instrumental delivery or I have to take her for cesarean? So you have to tell that is it suitable for what mode of delivery is what you want to assess. So your ST2 will do the vaginal examination to assess how we can deliver her because this is a pathological CTG, she's fully. You have to deliver her. So you will do the conservative measures and see if it is not improving. If not improving, in such situation, you have to assess for delivery either instrumental or cesarean section. So these are things you have to mention. How long is the active second stage? If pathological CTG doesn't improve with conservative measurement, then I will plan the delivery either instrumental or cesarean. So if you say that, they will understand that you know how you're going to manage. So ST2 will go in this room. Then this one you told correctly, para 1 delivered, so nothing much, awaiting suture of repair. So you will tell the midwife will do this. Midwife here can do the suturing of the 1 or 2, which you told very correctly that first or second degree tear the midwife will do. So that's perfectly all right. Midwife will go in this room. This is not for you. Then the VBAC fully dilated, pushing for 1 hour under epidural. So you told correctly she's under epidural, so we can wait longer. So I will be. This is not an emergency, so midwife will go there. There's nothing alarming here, nothing going on. This is a VBAC fully dilated, pushing for 1 hour, so you can wait further. So the midwife only will go there. No need of you going. You will just tell that the midwife will go and assess and make sure. Here, because it is VBAC, we'll make sure that she has IV line, she has group and save, and then if there is any CTG concern, she's hydrated, she's comfortable pushing, the epidural is working well. This is what you have to make sure, which midwife can do. So midwife will go and make sure that everything is all right with that woman. there should be IV line and group and say for this woman. She might need anything. So this is what. And then after 1 hour of further pushing, if she doesn't deliver, then I will go. After once I free from this room, I may have to go in this room if she doesn't deliver in further 1 hour. So this is what you have to tell her. Sometimes you have to extract extra information like how is the CTG? I want to know how is the CTG. So they will give you, hand over you the CTG. So you should be aware of all this. If you will not ask for CTG, they will not give you. Might be the CTG is bad. Here it is not mentioned anything about CTG. So you have to ask how is the CTG? I have to make sure how is the CTG. So these are the things. IV line, baby, if not mentioned about baby, how is the CTG? Mother fully dilated, so how is the station and all that thing? And pushing for 1 hour, so how she is comfortable is what it means. So nothing alarming here. If the CTG is all right, the midwife can take care of her. Then the cord fell, so this need consenting to cesarean section, which can be done by ST1 or ST2. So because the cord failed by midwife, so some doctor has to go and counsel the women that you need category 2 cesarean and which is urgent. So you have to send your ST2 according to what you have, either ST2 or ST1 or whatever sparing. If you have sent your ST2 here, you can send your ST1 here. And your ST1 is going to take the consent, and ST1 will tell the midwife coordinator to arrange the theater, inform the anesthetist, make sure that she is having group and safe. Anybody going for surgery need to have consent, pre-medication, and informing the theater. So these three things you have to do. So you'll tell that I'll tell the midwife to give the pre-medication, inform the theater and anesthetist, and make sure the group and save is available, and take the consent, and make sure she is not a Jehovah's Witness. Whenever you are taking a consent, you always have to make sure she's not a Jehovah's Witness. That is a safety point. She might refuse blood, so you should be aware of that. So these are the work: pre-medication, consent, IV line group and save, inform the anesthetist, mobilize her for CS. Inform the consultant because I am busy with this patient. You have to tell I am busy with this patient. My ST2 or ST3 is busy with pathological Ctg patient, which might need to go to theater. This might not need to go to theater, and this definitely need to go to theater. So you will inform your consultant that these are the patients who are supposed to go to theater. This need a category 2 CS and I'm busy with this patient, so I cannot attend that. So my consultant will be doing this cesarean because I am busy here. Or if my consultant will take this PPH patient, I can go and do the cesarean for this patient. So this is a category 2 CS because CTG is reassuring. So you have to tell this is a category 2 CS because CTG is reassuring. So either me or my consultant will go and do the cesarean as my ST23 is busy here, as the midwives will go here. So you still finished all the critical things. Three critical things were there. One is PPH, one is pathological CTG, and one is grade 2 cesarean. So these three you have managed well. One place you went, one place you sent your consultant, and one place you sent your whatever ST available with you, 2 or 3. And one has gone here and done the pre-medication consenting and informing everybody and arranging the transfer to theater. So well done. Then this APH lady, once my ST1 will finish the consenting part here, he will go to this room. You have to tell like that. Once my ST1 finish consenting, he will go to the APH patient because she's preterm. So he will, the ST1 will make sure, take the history, look for the placenta. If APH, is it a placenta previa or abruption? So look for the history first, check the scan for placenta previa or not, check the CTG for contraction, examine the women for tenderness, is it abruption, check the fetal heart, check the vitals is what you do for any bleeding patient. So you keep both in mind, is it abruption or is it placenta previa? So checking the scan, checking the previous history, any previous episode of bleeding, and then now in this scenario, check her vitals, check the mother, check the baby, and the CTG and the contraction. So this is what you will do. She had an APH of 175 ml, but now no more bleeding. So you are going to do the conservative management because you told nicely that she's B negative, so NTD will be given. So that all you'll make sure. Then, because this is an APH, you have to cross-match the blood. So I'll make sure that the IV line is there and the blood investigation has been done for her. And the blood is cross-matched for her. So this is what you need for her. So my ST1 will go there, and these are the things the women require. The patient need this, like that also you can talk, that my ST1 will go there, assess the record, assess the patient, assess the CTG, and we will make sure that IV line is done and blood investigation is sent, cross-match has been done, NTD has been given. So these are what you want to do. And then because this is a preterm, always the role of neonatologist. And by the way, neonatologist is also there in the MDT meeting in the morning. So if you inform them any preterm, they will go and talk to the patient. So I'll inform the neonatologist about the preterm, the chance of preterm delivery. Whenever there is a preterm, you have to give the steroid. So I will discuss with the patient about the steroids. So your doctor ST1 will go and discuss about all these things. So preterm means steroid, neonatologist, and the assessment for need of delivery, and the bleeding how much, and the placenta, and all the vitals is what required. So always don't miss the neonatologist part and steroid with the preterms. Then this 40 week CTG shows early deceleration at 9 cm. So nothing important for her. Early deceleration at 9 cm is perfectly all right and normal. It's a normal CTG. So that means CTG is normal. Because she is meconium strained amniotic fluid, she needs continuous fetal monitoring. So the midwife will go to that room and she'll take care that continuous fetal monitoring is done. Women is comfortable, hydrated, pain relief has been given. So in labor patient, basically you need to make sure that she is hydrated, pain relief is given. How is the she progressing in labor and how is the baby CTG? These four things you want to make sure. Her vitals, her analgesia, her progress, and the baby's heartbeat. So these four things you have to address. And whatever situation has been given accordingly, you have to mention because this is a meconium strained amniotic fluid. I want to do the continuous fetal monitoring for her. So you will tell that. So they should know that you know that because it is meconium, you are doing the continuous monitoring. I'll make sure I will follow her partogram. Is she progressing well? Because nothing has been given. So you don't know. I will see her partogram, how she's progressing. Is everything is all right with her? How good is her pain relief? This is what you have to make sure here. So here the midwife will go. So room 3, room 4, and room at the end you have to conclude. At the end you have to conclude your prioritization. So you will tell room 1 I will go, room 2 my ST2 or 3 will go, room 5 my ST1 will go first, and then after that room 6 my ST1 will go. And once I become free from this room, I would like to help in room 5 or room 6. Room 6 is your last priority, so I will go to room 5 to help with the cesarean. I'll inform my consultant and he will take over one of the patients because there are 2-3 liable patients to go to theater. So you have assigned it, and room 3 and 4 and 7, the midwife will go. So this is how at the end you should conclude that who will go where, because they have asked you that only. You have all these and who will go where. And there is always a midwife coordinator. So you always have to assign the task of coordination between theater and the labor room by the midwife coordinator. So am I clear how you'll prioritize and at the end, how you will utter about the final conclusion, where you will go and where who will go? Am I clear?
Yes, ma'am.
Okay, great. So let me give you some tips how you should talk about. Whenever you talk about labor ward prioritization, you have to follow the Sbar tool. So we'll discuss about that. What is Sbar tool? What is the situation? Here the situation is a para 4 just delivered. So I have a para 4 just delivered. So I am suspecting atony. So what is your situation? Para 4 just delivered. Background, she is a para 4, so she is at risk of atony. So background means usually not much of background here because they will not give you enough information. So background is okay. Once you say that I have just now delivered patient who is para 4 with bleeding. So your situation is PPH. Your background is vaginal delivery just now para 4. That is your background. Your assessment will be to check her vitals and assessing her uterine tone. This is your assessment. And your recommendation is to pull the emergency buzzer, call everybody, put the IV line, send the blood, drain the bladder, massage the uterus, give the oxytocin. Next step to go to theater. So this is how you will tell. Situation, PPH, background, just now delivered para 4, so chance of atony. Assessment, check for her vitals and the uterine tone. Accordingly, decide what to do next. Pull the emergency buzzer. Recommendation, arrange everything. What all to be done. This is how you have to inform. Now the same thing, like here. If you will tell this is a cord presentation, here we are dealing with because now you have assigned this room to ST1. So here the patient is cord presentation. You don't tell now, I will do this, I will do that, because you are busy here. You're not going to do this. So you'll tell, I'll send my ST1. And here we are dealing with a woman with cord presentation with normal CTG. So she need a grade 2 cesarean section, right? So situation here, cord presentation with normal CTG. Background, she's primary, 39 weeks, full term, 6 centimeter dilated with intact membrane. Assessment, uh, in assessment, you want to do her IV line, group and say these are done or not. Then your recommendation, the 4 things I told you, pre-medication, consenting, group and save, inform the theater, shift to theater, inform the consultant because you are busy here. So this is how you have to do the Sbar for the women. Now here you will say situation APH, background, she's preterm, G2P1 preterm. Assessment, you want to do the vitals, check the contraction, check the baby. IV line, check blood sent or not, NTD given or not. These are the assessment. And these are your recommendation, if not done, to do all this and do the observation for her. And counsel the women about what are the possibilities. This is also important, informing the neonatologist, giving steroid, counseling the women. Whenever you need counseling, you have to mention that you will inform the women about, discuss the women about what situation she's dealing with. So that is also important. So as I told you, how to prioritize who will do what is very important. So better to go room wise, and you might say that I'll go room wise and prioritize, and my prioritization may change according to the scenario, because sometimes if all the information is not given and in between the kid giving you information like CTG, so your priority might change. You go to PPH always, the bleeding patient always. But sometimes if you don't have any pathological CTG and in between they give you a pathological CTG, in place of suspicious CTG, you will go to pathological. So your priority will change. So you tell that I'll go room wise and prioritize, and my prioritization may change according to the situation. And who will go where, when, and what they will do is what they want to know. So you always look for the most urgent case. Like here, you will tell that this is the most urgent case of a PPH. So I will go in this room myself. So tell that this is the most urgent case, and I will go here. I personally will go here and assess the patient. So I will go here. Tell that. Then you will send your ST3 to the next urgent. Like here, the next urgent is pathological CTG for assessment and decision making because fully dilated. So you will send your ST3. Sometimes if they give you pathological CTG not fully dilated, so even the ST2 can go and assess the CTG, do the conservative measures, still you are busy somewhere else. Because it is fully dilated means they want to make a plan for delivery. That's why you have to send somebody who can make a plan. So ST3 can go here. Your ST1 will go for counseling or apology. If sometimes you're getting late, your ST1 will go for apology. Like the midwife will apologize here till the ST1 is coming. ST1 will go first here. So sometimes you have to put these words like apology. If you're getting delay, sometimes there is induction of labor station. A patient waiting for induction for 8 hours, nobody has done induction for her. So you will tell the midwife will apologize to her that we are very busy in the labor room. So induction might be delayed because that is an elective thing. So apology word is also very important sometimes to give. Counseling always is important. Anesthetist mainly will go for pain relief and in emergency. Like here, in emergency anesthetist will come in place. Like here, if she need to go to theater, you have to inform the theater anesthetist, which is separate. So there the anesthetist. Sometimes if epidural is not working well, if pain is too much, then anesthetist will take care of that issue. So anesthetist mainly for fluid balance, like in PPH for fluid balance, and if epidural pain relief is working well or not accordingly. Then the midwife can do the IV line, vaginal examination, episiotomy, suturing. All this is done by midwife. Don't think that episiotomy, suturing cannot be done by midwife. She can do up till grade 2. Up till grade 2 tear and episiotomy, she can suture. She can put IV lines. She can do vaginal examination every 4 hours, which is required. Sometimes you have to mention how frequently they need the vaginal examination. That is also important. If they give like prolonged labor or some scenario, then you have to tell that I will reassess her after 4 hours or I'll reassess her after 2 hours if slow progress. So that all things you should mention. Is it a suspected delay? It is a confirmed delay. These all words you have to use what is written in the guideline. Labor ward coordinator can review the CTG. So sometimes, supposedly, if pathological CTG, you don't have enough hands, it is not fully dilated pathological CTG, even the labor ward coordinator can go and review till you get free from some other urgent and come back. So you always have to tell, this is not your first priority for the coordinator to send, but because you are busy here, your ST3 or ST2 is busy somewhere else. So you will tell the midwife coordinator to have a look at the CTG, start the conservative measures. As soon as you will get free, you will go and have a look. So that is a possibility sometimes. So labor ward coordinator can review the pathological CTG if needed. First, the midwife, immediate midwife will review. If she find any difficulty, she will inform the coordinator. and then they come to the doctor. Or sometimes they directly come to the doctor, skipping the coordinator. So coordinator sometimes can review your CTG because they have expertise in CTG. So this is how you are going to assign the task to different people. Postpartum women needing fluid balance and care can be seen by anesthetist sometime if it is not related to PPH or something else, like pain relief in post-op women like that, anesthetist can take care. No need of you going there. So these are the things. Whenever a postpartum woman is there, always keep a mention of the baby. I'll make sure that she's aware of the baby. She has the baby is all right. All that thing. Just a simple sentence for the baby will be a good idea for a postpartum woman if it is not an emergency like here. She's waiting for the therapist, so you can simply say that I'll tell the midwife to make sure that she has started the breastfeeding or baby is doing well or mother is informed about the baby or whatsoever. So one sentence should be enough for that. Whenever a B negative blood group, any negative blood group, NTD is important for post delivery. You have to tell that we'll check the baby blood group and accordingly the NTD will be given. You have to tell that we might have to do the group and save for her because it is rare, and sometimes the methargine argometrine has to be avoided for her. So these are the information you have to mention if she's in labor. So this is how you will prioritize who will go where. And always inform your consultant if you have 2, 3 things urgent. Always you have to communicate with your consultant who will come in play and do the things and arrange the things. Okay, so you have to follow the Sbar as I told you. Tell the situation PPH, tell the background para 4 just delivered, tell the assessment, all her vitals and all that thing, uterine tone, which is what you want to assess. Tell the recommendation, pull the emergency buzzer, arrange everything. And she might go to theater to communicate. So this is how you will inform always. And this is what the tool they use for communication. So Sbar, you can, in the beginning, you can always say that I will be following the Sbar tool for communication. That's also a good idea. That means you know the word. So you will get an extra mark for that, that you know the word and you're going to follow that. You will tell, always in the beginning, you tell that I'll go and introduce myself to the patient. When you go to a PPH room, you will go and introduce the patient and tell that many people will come in, many doctors will come in, many people will come in because we are dealing with an emergency. So informing the women is also important because she will get scared. Why suddenly so many people came? So you will tell that we are dealing with an emergency and many people will be coming in. So that is how you introduce yourself and tell the women, make her aware about the situation that we are dealing with an emergency, like in PPH, like in shoulder dystocia. You have to tell like that. I'm sorry, we are dealing with an emergency and many people will come in. Don't get overwhelmed. One midwife will be there to help you, support you. So one midwife will be at the head end supporting, one midwife will be scribbling what is happening when. So these are all important points you should keep in mind. Utter these words is important. What all words to utter is important. I'll follow the partogram. I will give the apology. I will look for the active pushing hour. I will look for the analgesia, uh, hydration. In pathological CTG, we will do the conservative measures, fetal scalp stimulation. So these are things what you should utter in labor ward. Always introduce yourself. You have to do the information gathering. Usually the midwife will give you information and some will be through the notes. Special handover, if anything given to you in the handover, you should take care of that. Mother is always your priority and then the baby. So always you will go to the station where mother is at risk, like PPH, APH or rupture uterus, where both are at risk. So mother is always your first priority. Keep that in mind. And then the baby. So after catering the mother station, you will go to the baby station or somebody else will go to the baby station and take the initial lead till you are finishing and coming back to that room. You have to use all this word I already told you. Always ask for Jehovah's Witness before surgery and consent. So whenever you're taking a cesarean consent, always utter the word of Jehovah's Witness. I'll make sure that she has no objection to the blood. She's not a Jehovah's Witness. So this is always we do. So keep that in mind. Look for contraindication of argometrine like high blood pressure. So if high blood pressure women preeclampsia is given, always mention that I cannot give her argometrine for oxytocin because she is high blood pressure. So they should know that you know that high blood pressure argometrine is a contraindication. And whenever you are giving a drug, after ruling out the allergy, a word mentioning is a word because that is a safety point. After ruling out allergy, I will be giving this drug to the women. So this is important. Am I clear about this till now? Then I'll tell you what are the grades of emergency. Okay, great. So grades of urgency usually urgent, semi-urgent, and routine. So urgent will be, as I told you, bleeding, feedback rupture, where both are at risk, sepsis. These are the emergencies. Severe preeclampsia, eclampsia is an emergency. Bradycardia is an emergency buzzer. They keep pulling the emergency buzzer for bradycardia. Some days in labor ward, I get 10, 20 emergency buzzers. So bradycardia is an emergency buzzer. Shoulder dystocia is an emergency buzzer. PPH, all these things are emergency buzzer. The midwife who is giving one-to-one care will be pulling the buzzer and you have to rush into the room. Cord prolapse is an emergency urgent. Pathological Ctg is an urgent one, but pathological Ctg means it's not like immediately you have to do something. You have sometimes few minutes for conservative measurements and reviewing the Ctg. So it's not a dire emergency where you have to go first. You can even send somebody else for the beginning part. But all other, you have to go yourself. Like here, they have given cord prolapse with stable CTG. So no need of you going, somebody else can go. Otherwise, if cord prolapse with abnormal CTG, that will be category 1. So you will be rushing in there after BPH and APH, of course. So this is how you have to prioritize. You have to tell, this is my most urgent patient. This is my first priority and I will go in this room. Always tell that. I will go in this room. I will send ST3 to this room. I will send ST1 to this room, and once she's free from this room of consenting, she will go to the APH lady. I will send the midwife here. My dear Farheen, they will never give you two stations where you have to go together. They will never give you a PPH and VBAC rupture together. They always give you a space. They always give you one very urgent where you have to rush in, and they will give you one like urgent, but still somebody else can go. So here you will go, one of these you will go, and here you will send somebody else. For pathological CTG cord presentation, you can send somebody else. So believe me, they will never play with you like that. They always give you only one most urgent where you will go, and the other you will assign to other, which is assignable. So you can assign. Then the semi-urgent. In semi-urgent, prolonged second stage, any prolonged labor with normal CTG is a semi-urgent thing. They need assessment to make a plan, but they don't need it now. So you can wait on them. So if you are dealing with all these things, they can wait. So this is semi-urgent, prolonged labor with normal CTG. Or suspicious CTG is also a thing which can be managed slowly. So it's not an urgent one. You can keep them on conservative measures. The labor ward coordinator can see them. So it's not a very urgent thing. But definitely it's after this is your priority. Prolonged labor and suspicious CTG is your priority after this. So if you don't have all this, you can go here. And then the routine ones like preterm labor, PPROM, only need counseling and talking that how we are going to manage you. We will liaise with the neonatologist, we will give you steroids. So more of talking and taking their history is what is needed. So even ST1 can go, or if you are free, you have nothing to do, you can go. And then the routine thing could be meconium stained liquor with normal CTG. So you have to keep an eye only ECV, IOL, CAT3CS, IUFD for postmortem counseling. These can wait. There's no emergency in this. So this can be dealt with routinely. So if you are very busy here, you'll simply say that midwife will go and apologize with the patient. Because the labor ward is very busy, the patient will be seen after some time. So midwife will go and apologize. So here the apology comes. You will go here. After finishing this, you will go here. If you have somebody in your hand, you will send here. Otherwise, the midwife will go and give an apology is what you have to mention. So am I clear? Now, how to prioritize who will go where, what all words to us utter whenever you are doing, how to do it in Sbar tool, and how to grade the urgency. Are you clear about labor ward prioritization now? Okay, great. So this is how you have to, once you start practicing in this way, it will be easy. Believe me, it's not very difficult. And it's not like you have to mention each and everything. We know each and everything, but it's not necessarily, but you have to tell that you know. You have to show that you know. How you will show that? Para 4 attorney is common. IOL for IUG are so low threshold for intervention. fully dilated, so I have to assess either instrumental or, as she is a pathological CTG with full dilatation, she needs delivery. So I will assess if we can deliver her by instrumental delivery or we have to do cesarean. So tell what is running in your mind. Cord presentation, need category 2 CS, so need all these things. So what is the situation should be clear in your mind, then only you can tell. Like early deceleration, it's a normal CTG, so she only needs continuous monitoring of the baby. So if you utter these kind of sentence, they understand that you are understanding what is going on. You're not telling vaguely. It's clear in your mind that what this woman is and what this woman need. So if you say that, you already get the mark, even if you don't tell that I will put the IV line, I'll send the blood, it's okay. Here you make sure that IV line is there and group and save is there. But if you say that she's a VBAC, there is a high probability of intervention, but she's pushing only for 1 hour of active pushing. So she's under epidural. So according to the recommendation, I can wait for 1 more hour. They are happy. So like this, you should tell what is written in the guideline and what you understood by the station. So very well done, my dear, and practice more and it will become more and more finer and flawless. Okay, great. So let's go to the next station.